It's my pleasure to be coming to you from ASCO 2023, and I'm joined today with Dr. Andy Armstrong, discussing two really important and really interesting studies in prostate cancer care. So first I'd like to talk about your work looking at an AI biomarker to really help us personalize the care of patients with high-risk localized disease and their androgen deprivation therapy. So if you can sort of give us some context for this, there's many randomized trials telling us that longer is better and 3 years is what we should be doing. And so what's the rationale for even looking for this biomarker?
Absolutely. Thanks for the invite to talk about this. I mean, men in my clinic, when they have high-risk disease, they can either choose radical prostatectomy or radiation and hormones, and it's a standard of care to offer 2 to 3 years of ADT. Some of these men suffer long-term consequences from that. The long-term side effects are sexual, bone health, muscle, fatigue, loss of stamina, and some of these men can do quite well, possibly with a shorter course, and that was the objective of this NRG study. So we sought out to see if an AI biomarker could help solve this issue of, do all men need a long-term ADT, or can some men get away with a shorter course and have excellent outcomes?
Right, and we've seen this biomarker with a prognostic value before.
This is actually a different biomarker.
Okay.
So while we're using the same methodology of AI and machine learning and a neural network to look at digital pathology as well as clinical variables, this was uniquely trained on the high and intermediate risk subset of patients through the NRG cooperative group, and then validated on the RTOG 9202 phase 3 study. So it's a different biomarker than what Dan Spratt presented, for example, which is more an intermediate risk multimodal AI biomarker, and so it has unique features that is distinct.
Got it. And just to summarize for us, can you give us an overview of what you guys found in this work?
Yeah, so first off, digital pathology is the main biomarker component, but it's not the only component. It actually factors in age and PSA and T-stage and Gleason score, which makes up about half of the biomarker. But critically, 40% is something that is not captured in standard clinical variables, the AI pathology. The machine learning algorithm will take into account the digital pathology features that are actually associated with a predictive value for long-term ADT. So that's how it's trained and then externally validated. What we found is that about a third of men with high-risk prostate cancer test AI biomarker negative, and they have excellent long-term outcomes with short-term ADT. And there was no benefit in that group from long-term ADT, meaning they don't need long-term ADT. That's a huge finding. We can spare them the therapy. There's an opposite group that are intermediate risk patients. About 40% are AI positive. And these men have a poor outcome. They're kind of like high-risk patients by AI. These men need long-term ADT because they have a poor outcome with short-term ADT. Right. So it kind of gets at the limitations of our clinical criteria that AI can see beyond what the clinical pathologist is seeing. These men who are AI biomarker positive would benefit from a more treatment-intense program. Right. There's a third group of men who are AI positive, who receive long-term ADT, but still fail. They still develop distant metastases, which is our primary endpoint in the trial. These men, in my clinic, would probably be the ones that might need abiraterone or a potent AR inhibitor, or might benefit from PET-guided radiation, where you're guiding the beam to metastatic sites. These would be higher risk patients, but now an AI algorithm might be able to identify these kind of three groups of patients where clinical practice could be altered. Right,
and so, we have really impressive data, I would say, presented here with nice external validation. What do we need to do to take this from, the halls of ASCO into our clinics?
Well, the first step is to get a CAP and CLIA certified and FDA cleared test, or at least recommended in NCCN guidelines. The Artera AI platform just requires a digitizer for prostate pathology where that image is then shared and then the biomarker is returned. And this can be done very rapidly as long as there's appropriate digitization and validation using different platforms. So I think that's the next step, is the clinical rollout. The future research steps would be to apply this to other contexts, such as that higher risk group that testing positive for the AI biomarker, but maybe randomization to a more intensive therapy. So see if we can further improve the risk of distant metastases in these patients.
Right. So it seems like there's opportunities to both de-intensify
both.
and to intensify, and so
Absolutely.
we can really provide a more personalized approach to our systemic therapy here.
That's the exciting part of this.
Absolutely. And speaking of treatment intensification, maybe we'll transition to the other big presentation you're giving here, which is looking at patient-reported health-related quality of life from the PROpel trial. And so maybe give us a little context on the PROpel trial and why health-related quality of life is so important for these patients.
It's a timely presentation because just this week the FDA approved the PROpel regimen, which is abiraterone plus olaparib, in BRCA-mutated patients based on this data. In Europe, many more countries have a broad approval for unselected patients in the first-line mCRPC setting. The PROpel study was an unselected trial population. The way that we designed this trial was to see if the combination could delay progression-free survival and subsequent overall survival as compared to an active comparator, which was abiraterone. The purpose of the poster today was to examine not efficacy on hard endpoints like survival and rPFS, which we've presented previously, but to look at the impact of this doublet therapy on quality of life, delaying pain progression, time to opiate use, symptomatic skeletal events, and delaying the need for chemotherapy. So that was the main purpose of this.
Absolutely. And so I think it depends how you view this, whether you're a glass half empty or glass half full person. But I'm interested in your sort of thoughts on the data and how they played out, because from my take is we really see no difference in the health-related quality of life. And you can either see that as you can give more therapy without harming quality of life, or conversely, we have an agent that improves progression-free survival. We should have better disease control, and yet somehow we haven't gotten better patient metrics in spite of that improved.
I'll take that in a couple parts. First off, when you're a patient with mCRPC, you're dealing with competing risks, right? You have the disease itself, which can impair your quality of life, and then the treatment, which can cause harms. When you're talking about two treatments, you're talking about extra possible harms. So when you're looking at quality of life in an asymptomatic patient population, which was 80% of PROpel, the main goal is to maintain that excellent quality of life and to prevent deterioration. We don't show any worsening of quality of life with the doublet. We can't say that it's better. We don't expect it to get better when you're already asymptomatic. In the BRCA patients that have a phenomenally huge benefit, we also don't see a big impact on quality of life. So as our positive control, where patients are having a hazard ratio 0.2 for rPFS and survival, there's really just a 3-point difference in the FACT-P score. That's a pretty small difference. So even in the group that's benefiting the most, quality of life is not particularly sensitive to some of these changes. Most patients who experience a radiographic event are not symptomatic when that happens. A lot of these symptomatic events happen in the 3rd or 4th year of life, not necessarily in the first 1 or 2 years, which is where most of our data is there. We do show more profound effects on delaying opiate use, skeletal events, and chemo, particularly in the BRCA population. And so I think all of this goes into the risk-benefit calculation, so you can make individual choices for your patients. Certainly a BRCA2 patient, there should be a definite discussion and consideration and guideline-based use and approval. But in patients that are non-BRCA, there are some benefits. There are some benefits in delaying progression, but there are some harms. We don't see worse quality of life, so that's part of the factor.
So it seems like the major takeaway with health-related quality of life at this point of time is that we can give these treatments in a way that preserves quality of life.
There are side effects. Anemia and fatigue are notable, but most of that does not result in a significant impact on quality of life, where still men can they rate their bother as a little bit, but it's not a lot. We didn't see many patients suffer a 10-point drop in their FACT-P score, which is what we consider clinically significant.
Well, I want to thank you so much for your time and for the data you're presenting this weekend. It's important for advancing the care of our patients with prostate cancer.
Thanks so much.
Thank you.